Hi, everyone, and welcome to this Friday webinar by Wonka Africa on the family medicine in action in Africa. I'm with Daniel Darko, who's a family physician or family medicine registrar in Ghana, and he's quite an interesting person. And I think I just want to stop the sharing. Welcome, Daniel. Perhaps you can share your screen and unmute yourself, and I can introduce you briefly to the people that are listening in. So, Daniel, you are a registrar or a trainee from Ghana, and you're going to talk to us today about life as a trainee family doctor in Ghana. And I'll just go through what you've shared. You are finally a medicine resident with the Ghana College of Physicians and Surgeons. And you're training at Nyaho Medical Center, which is a private center in Accra. Do you want to tell us why? Tell us about Daniel. Daniel, share us a little bit about who you are, anything curious about yourself. Just tell us about you.
Okay, so thank you so much, and good afternoon to the participants. My name is Daniel Darko. I'm a final year family medicine resident, as Prof read out. I am married. If you saw my profile picture, I am married to a beautiful woman called Natalie Edu, and we have a set of twins, so a boy and a girl, who are about 4.5 years now.
Wow.
I've been working. I graduated with a Doctor of Medicine degree from the first Moscow State Medical University in Moscow, Russia. Right. And I came to Ghana. So as it is, you usually write an exam so that you can be licensed in Ghana. So I wrote the exam, and then I did my house job.
Before we get there, I'm curious.
Yes, please.
Before you get there, let's just get an understanding. Why did you land up going to Moscow? I mean, is it a challenge to be trained in Ghana as a doctor?
Okay, good. So
tell us a little bit about that.
When I finished senior high school, I made the grade. I got an admission to one of the universities in Ghana, in Kumasi, to be trained as a medical doctor. Right. But then there was a funding challenge. So my family, there was a hard time. We didn't have enough funds to cover the cost, even as a regular student.
Right.
And then I applied for a scholarship with the Ghana Scholarship Secretariat, and I qualified for that scholarship.
That scholarship was to Moscow?
Yes, please. That scholarship was to
I see.
So that was how I ended up in Moscow.
Essentially funding. All right.
Yes, please.
Great.
Yes,
well,
please.
At least we understand. But generally, where's your home place? Is that Accra or Kumasi?
So I was born and bred in Accra.
Right.
Yes.
Okay. So tell us about you basically came back and to Ghana.
Yes. So I came back to Ghana in 2013, and then I wrote the license exams for the Medical and Dental Council, passed that exams, and then I started a house job training for 2 years in 2014.
Okay.
2014. So I was posted to a district hospital. That's actually where I am right now, St. Dominic's Hospital in Akutia.
Whereabouts is that in Ghana?
So that is in the eastern region of Ghana. It's just about 3 hours drive from Accra, maximum. It's just about 3 hours drive from Accra.
Okay. So where did you come across family medicine and say, that's what I want to do?
Good. So in Akutia, there was a family physician who was practicing here in Akutia. And at the time, I think he was running the internal medicine department because there was no physician specialist on the ground. But then that particular doctor, he's called Dr. Bernard Togo. He was exceptionally good in almost everything. So you are in the ER, and you have a problem, you call, let's say, the pediatrician, you don't get him, you call him, he'll give you an idea, he'll walk you through the thing. And so that was my first exposure to family medicine or someone who is a family physician. And all together, I realized that he seemed to handle himself very well. He knew his stuff. He was very nice. He would teach you anytime you come into contact with him. So that was my very first exposure with him. And then I finished the house job training in 2 years, and I joined Nyaho Medical Center. Over there too, I worked with 2 family physicians. One is a consultant, one is a specialist. Dr. Osa Olayemi, and then Dr. Amavotia, who were equally very exceptional at their work. They would help you any point of need. And that was when I realized that, this is probably something I would like to do. This is the breadth of their knowledge and the ease with which they adapt to almost all situations. It's probably something I would want to do. So then I started looking into it.
Nice, interesting. That adaptability and the confidence with uncertainty. It's nice that you mentioned that, and their wide range of skills. Well, let me ask you this question: were the 2 doctors that you worked with in the Nyaho Medical Center also family physicians?
Yes, please. So those are family physicians in Nyaho Medical Center.
Right,
Yes.
right. So you had, I mean, you don't have a large population of family physicians in Ghana.
So in Ghana, if I'm not mistaken, I think the total will be less than 300.
Right. Yeah. Well, that's
practicing and retired. Practicing and retired all together is about 300, I think, or less.
Well, it's fortunate that you had experience and actually engaged and touched these people that inspired you, which is really good. Do you think that other students, other doctors get to see what family medicine is about and get inspired by it, or is there a challenge, you think, with understanding family medicine?
So I think the current training programs undergrad for medical students does not expose them so much to family medicine. I think 1 or 2 of our medical universities sort of expose them with a number of lectures, but really they are not exposed to, let's say, the faculty or the department and the things that the family physicians do. Usually when you get onto the job, when you are posted to, let's say, a district hospital, usually you meet a family physician there. And there you actually be exposed to the person and what they do, and you may probably be intrigued by their abilities and it may move you to join. But I personally, because of the private facility I'm working in, because I'm working in Nyaho Medical Center, we have consultants that come in to do other cases and come and see other patients. But the family physicians are usually on the ground day in and day out. So you are able to see them in action most of the times, yes.
Now, I'm curious, you are working in a private center and being a trainee. How does that work? How is your programs, working in Ghana? Do you all have trainees moving public, private? How's it working? Tell us more.
Okay, good. So currently the Ghana College of Physicians and Surgeons have accredited a number of facilities for training in family medicine. So there is the Kolebu Teaching Hospital, there's Konfanochi Teaching Hospital, there is, I think that's a Kwashi Memorial, and then Nyaho Medical Center. These are the 4 main training facilities for regular residents. And then we have a few more accreditations for other centers that are running the modular program. So their program is a bit different from ours. But those of us doing the regular program, we are doing a 3-year membership program. And so in my facility got accreditation, I think 2017. So I'm actually part of this. Yes, Nyaho Medical Center actually got accreditation in 2017. And I'm part of the second batch of residents that were recruited for training. But thankfully, I was already a staff at Nyaho before the accreditation, and then I joined the program. So because our center is a huge center, so our center, I would say, is huge. We're about 50 to 60 bed facility.
Right.
But then we have a huge outpatient department. We have a theater. We have a huge emergency room of about 12 beds. And then we have in-house specialists. So I think we have about 7 or 8 in-house specialists. And then we have all the contract staff who come in to run clinics in almost every specialty.
Right.
And so our training, even though it's a bit different from those in the public universities or the public hospitals, we still do some rotations. So rotations that are not very solid in Nyaho Medical Center, you do it in, let's say, a teaching hospital or in the regional hospital in Accra. So it's more of a partnership between Nyaho Medical Center and some other facilities in Accra to run the 3-year program.
So what sort of specialties do you land up that aren't solid, so to say?
So let's say our ONG, for instance, our obstetrics and gynecology, we have one specialist on the ground. And then we have, I think, about 7 or 8 consultants that come in to run clinics. And so the patient load, even though it's high, the variety is not so much.
Right.
The variety is not so much. And the activities in terms of the surgeries, the procedures that are carried out is also not so much. And so usually it's better you do the first part of the obstetrics and gynecology in-house at Nyaho, and then you do the second part, which is another 6-week rotation in Greater Accra Regional Hospital, for instance.
Right.
And then we do surgery as well. You do almost all the surgery outside of the facility because we don't have an in-house surgeon.
Right.
We do ENT outside, we do urology outside. So we do a couple of rotations outside the facility. Yes, please.
Right. But most of the time is spent in the facility. You know, of the 3 years, you'd say half or more.
So of the 3 years, you spend just about a year in the facility. You spend just about a year at Nyaho Medical Center. And then you do your district rotations, you have some leave time, you have some revision course, and some, so you spend about a year in the facility. But now we're expanding. The facility is expanding in terms of capacity, and I think the current first years are doing more in-house as compared to our batch.
Right. So how many in your batch, number of registrars?
So my batch, there are 3 of us. Myself, Dr. Flores Budumanuel, and then Dr. Irajwa Kankamyeboa.
Right.
There are 3 of us.
And how many family physicians in Nyaho totally?
So in total, we have 1, 2, 3, 4. We have 4 family physicians. 1 is a consultant, 3 are specialists, and then we have our training coordinator who comes in as and when to help us with some other activities in the facility as well.
Right. So in terms of your sort of clinical program, you've mentioned you go through, work in the clinic in that center, and then you go out for rotations to do work. What sort of, and just tell us a bit about the community that this Nyaho Health Center serves. Is it what's the size, and how do they use the service in relation to other services nearby?
Okay, so Nyaho Medical Center is Nyaho Medical Center is actually the first private healthcare facility in Ghana that was established in Ghana. This year will be 51 years as a facility.
Wow.
And over the time, it's been serving a huge population of middle and high class people or population in the country. It's become a go-to name for the middle class and high class population in Ghana, specifically in Accra specifically. And we have a patient population. I think we're actually located at the airport residential area, which is sort of very central in Accra. And so it allows people to come from all parts of Accra to the facility.
Right.
And because of the multi-specialties that we have a lot of people coming in every day for outpatient services, for emergency, and then for inpatient services as well. Currently, we run an outpatient department which sees about 400 plus patients per day. See about 400 plus patients per day. And then our inpatients up to about 40, 50 beds for both maternity, surgery, internal medicine, and all the basic specialties as well. Most people access our facility with health insurance. So we have about 70% of our clientele coming in with private health insurance, not the national health insurance. Yes. Not the national health insurance, they come in with private health insurance. And then you have about 30 to 35% of our population, patient population, coming in with cash, paying their own from pocket, out of pocket.
Right.
Again, because I say we serve a middle to high class population, even those who come in with cash usually do not have financial challenges. They are able to afford the services and they are able to go ahead with treatment as needed in the facility.
So it's a, as you say, a very central in Accra private medical center that services high middle income communities. Yes. And so you've got a very wide community across literally all of Accra that comes
so we don't
to you.
have a fixed marking as in this area is our community specifically. Yes. We have a huge patient base, so we see about 100,000 per year from different parts of Accra. Some actually come from outside Accra. We have a few expatriates that actually come from Liberia and Guinea on occasions to equally come and access the service. So we don't have a defined geographical area for our community. But then for this huge number of people, they actually come to the facility for primary and secondary care.
That's interesting. So in terms of good primary health care, you have to be first contact. So I guess people come to you and you learning how to manage people with undifferentiated cases. So they don't get referred to you. You see them as their first port of call. So what about, continuity of care? I'm sure you have a comprehensive service, you're coordinated, but I'm curious, do you have a panel of patients that come to you, or do they sit in your waiting room and see whoever there is free? How does your system work? And how do you...
So currently we've established a family practice clinic. We've established a family practice clinic where the 3 family physicians on the ground actually run those clinics. So they sort of have a patient load that come to them on a regular for continuity of care. But for those of us who were, let's say, medical officers before we joined the program, or those residents, we don't have that pool yet. Right. And so as you see the patient, so when I actually joined the program, the family medicine training program, I began to appreciate the need for continuity of care, providing comprehensive care for the patient, trying to coordinate the care so that you can achieve some basic aims for this particular patient. And so for most of us in the training program, we go to the OPD or to the ward, depending on where your rotations are. And once you see a patient, you make it a point to actually schedule them. So this is something we are doing now. So once I see a patient, I'll tell you, okay, come in 3 days' time, I will be in the clinic, come and see me on this day and we'll do this. Or I'm referring you to this specialist. I want you to go and then come back, we'll continue managing all the other things. So now this is something we are building up on for ourselves. So I can say boldly that I equally have, let's say, about 100 or 200 patients that specifically will come to Nyaho to find me. So even as I am out of Accra for the last 2 months, I keep getting calls.
That's when you know that I'm having continuity. When they say, "Where is this doctor? Where's my doctor?"
Exactly.
My doctor.
So they keep calling you, and then you probably let them see someone, you discuss with them, and then you drop a plan because you have a lot more information about that patient. And so as part of the training program, I think we're actually learning that earlier on as a medical officer, I really didn't care. I see you, I write you your medications for you, go. You come next time you see me. I really didn't care about that. But then coming into the program and then realizing that, oh, there's actually a lot more beauty when you see them over time. So that you actually see what is happening to the control of their sugars. You see what's happening to the control of their hypertension, or whatever problem they came in with, the headaches that you refer them to the neurologist. What was the outcome? What medications were they put on? And so that, and actually begin to implement that in my practice.
Good. Well, that sounds great. I mean, it's always a challenge, this continuity of care, and actually over a long time, continuity, you only see its real beauty when you give it time. Exactly. And then you start saying, hey, I know better I can quickly sort this out. Exactly. And people love that relationship. And I think you feel touched, like you said, especially. Well, that's good. So how does it work in terms of the team? I mean, I'm not too familiar with Ghana and how, who are other clinicians? For example, do you all have nurses who are trained to be clinicians? Do you have clinical officers that are working? So how does the other members of that clinical team work? And do you all have that situation in Yahoo, or is it more in other places in Ghana?
Okay, so in Yahoo Medical Center specifically, our team comprises of nurses. So we have different levels of nurses, or yes, we have the healthcare assistants, we have the nursing assistants, we have the registered nurses, we have the nursing officers, and even some senior nurses that work with us in the clinic. And then we have medical officers. So medical officers who have finished their house job training and they are practicing as general practitioners or medical officers at the various units. And then you have the residents, you have the specialists, including the family physicians who are on the ground. So for most of us, especially in the clinic setting, it's the nurses, the doctors, the specialists. We run the outpatient department. And that is the team that works together to achieve the outcomes that we monitor at the OPD. And then in other places in Ghana, our primary care specifically is made up of community healthcare nurses, some nursing staff nurses or registered nurses, and then we have physician assistants and some midwives. So they actually man the very smaller unit. So we call it a CHIPS compound, community health and planning services. So they have just a compound with about 2 rooms, and they provide basic care, rapid tests for malaria, vaccinations, antenatal, basic cares in communities. And so that, together with some of the health centers equally have physician assistants, nurses, and then a doctor. But those are very few. And then we come to the district hospitals, which equally has the same set of people, the nurses, the doctors, the physician assistant. So we don't call them clinical officers, we call them physician assistants. But we don't have nurse practitioners in Ghana. That is one thing we don't have now. We currently do not have nurse practitioners now.
So your nurse who is with you in the OPD at Inyaho is not doing clinical work, she's doing nursing work.
Yes, please. So the nurses with me in the OPD or in the ER, they are doing nursing work. They are not doing prescriptions or pure medical. No, they are not.
And do they get involved at all in like chronic care or IMCI? Do they do that kind of thing?
So currently our setup, their role is mainly in the OPD. When I'm seeing a patient, they are with me, they are helping me draw a BP profile, they are helping me draw a glucose profile for the patient, they help with the counseling with the relatives in terms of some nursing care at home that is needed. In a few occasions, they actually do some educational sessions in the waiting area whilst the patients are waiting to come in.
Right.
But we are yet to establish a full-blown chronic care clinics. This is one of the projects we are embarking on 2021 and in the years to come, to establish a chronic care clinic, which usually would encompass everything: the nursing care, the educational needs, the pharmacy needs, and then the doctor's role as well.
But you say there are no nurse practitioners, that's nurse clinicians in Ghana at all?
Currently. So I think the Ghana College of Nurses and Midwives has actually started a specialist program.
Right.
So I think one of their program lines is adult medicine and then pediatrics,
You're trying to
in women's
develop the
health.
nurse practitioner.
Exactly. So hopefully in a year or two, we will probably get some nurses who are knowledgeable enough and well versed in trying to manage some of these cases as well, to help in clinical care. Yes.
Good. And so in Yahoo, do you have physician assistants who are working with you seeing patients?
No. So in Yahoo Medical Center, again, because of our clientele base, because of our cost, and because of the standards we are trying to maintain, we do not have physician assistants in our team of practitioners. What we have is the medical officers, the residents, and then the specialists.
Right.
We don't even have house officers, junior doctors. We don't even have junior doctors who are still in training. We don't have those as well.
Yeah, yeah. So I suppose the reason is, like you're saying, that you're not, I suppose, part of the public service, and also you are trying to deal with the different clientele.
Exactly,
Okay.
exactly.
Interesting stuff. So, this sounds like a place that is a useful learning space. And you're going through your 3 years, and you then write the college exam, which is Ghana College.
Yes. Yes, please.
How many students go through, or trainees write the Ghana College exams in a year?
So currently, the Ghana College, I think in a year will be around 100 to about 150
The total
residents that would write the exam. Yes,
or
the
family
total
medicine,
college. So that includes family medicine, general
other
surgery,
disciplines, of course.
pediatrics, and all of that. So I think about 150 residents usually would write the exam. Our year group, we're about 40 family medicine residents, which is final year now.
In the whole of Ghana.
Family medicine in the whole of Ghana. But even that, we are just about 25 doing the regular program. The other 15 are doing the modular program. Okay. So there's still a challenge of training space and enough trainers to actually train people.
And 40 will write the exam. Will 40 write the exam?
For my year group. Yes, please. For my year group, 40 will
that's
write
large.
in September,
I mean, that's
2021.
larger than even in South Africa. I don't think we are getting past 20. So you're doing very well.
The whole South Africa.
The whole of South Africa. So you're clearly doing well. Very good, very good. Keep it up.
Yes, we're doing better. We're doing better. Yes, yes.
So tell me, in terms of the modular program, how is that working different to what you do?
So the modular program is actually made up of doctors who have worked in the district hospital for more than 5 years.
Okay.
For more than 5 years before they enter the program.
All right.
So you work in
so
a
they
district
come with
hospital
experience
for more
already.
than 5 years. Exactly. So they come with experience. They write their primaries. Once you pass that, you enter the program. And then in the program, you still stay at your district hospital, whichever facility you are working in, you still stay there. But then I think every week in a month, so 1 week in a month, you go to an accredited facility close. So let's say if you're in Kumasi or in the Ashanti region, you go to Komfanochi or the other district hospitals that have specialists on the ground. And then you go and see a number of cases, present those cases, do some procedures under supervision, so that those specialists can correct you, can teach you, can sign your logbook for those specific things that you came to do, and then you go back to your facility. So almost every month, you do a 1 week sort of internship or 1 week attachment to a district hospital with the specialist that you need. So let's say I need to sign ONG. You go and meet an obstetrician gynecologist in a district hospital, and then the person takes you through, signs you out for those particular. And then every 3 months, every quarter, they have modular lectures. So they have a couple of lectures, let's say trauma, then the surgeons and all the college professors and consultants will give them all the lectures they probably need for trauma. The idea is that because they are in the district hospital, they are getting a lot of hands-on. And so what is needed is just to bring them up to speed on current knowledge, current evidence, and then give them the opportunity to actually implement that in their local facilities. And
Right.
so it seems to be a wonderful idea. It's helping a lot of the very senior medical officers that have been in the district hospital for a long time to actually get some structured education to come out or pass out as a member of the college. So
That
far, I
sounds
think the
good.
first batch of that modular student to be writing, they are supposed to write this March. So this next month, that's when the first batch will write their exam. Yes, but this is actually for 4 years, as compared to those of us doing a 3-year regular program.
Right. That was my next question, how long it lasts. Good. So 4 years, but still, being able to come for a week and then go back to the original place of work sounds like a very useful way to sort of build capacity in their facilities and also come out with a training degree. I mean, a program, a specialist qualification. So that's
It's actually an excellent program because these residents are actually in the district hospitals. They have a huge staff under their influence. So as they prepare, as they pass out, they are able to better influence a huge population of practitioners, physician assistant, nurses, community healthcare workers, and implement policies and agendas much better because of their knowledge, their experience, and what they've picked up during their program. So it's one of the excellent programs that have been brought up.
So how many are there a lot of doctors saying, I want to be part of this modular program? Is it very popular?
So currently, yes, it is very popular for the senior colleagues that have been in the district for a long time. It's very popular for them because it's very flexible. They're able to maintain their family life, maintain their work life, and then just a week out of a month, they come out. So it's really popular amongst them. I think the main difficulty is the fact that people have not passed out yet. So we've not seen the outcome. So a lot of people are waiting on the fence to see how it goes,
to see how
whether they pass out, whether they are absorbed into the system, whether they get all the salary or the benefits. And so I think some people are sitting on the fence, but then I think we have 4 batches in the program currently. So that's it's actually.
So once this doctor comes out, I mean, you qualify, you'll become a specialist. You then will do you all have a career pathing in the public service? Although you are in Yahoo, but in the public service, will they get a post that's better than that of a medical officer?
So yes, once they finish the program, they become specialists on their own, and there's a whole our pay system, our grading system for doctors. Once you become a specialist, you move into a different category. So you are no more in the medical officer. Your salary moves. Your all the other what's the word? All the other benefits equally improve as you become a specialist. So yes.
So that's and it's the same as other specialists.
Exactly, it's the same as other specialists, but most of the other specialties, none of them is actually doing a modular program yet.
Yes.
None of the other specialties.
I think it's probably good rationale for this because it's probably servicing a lot of rural communities where it's very difficult to build this up. I think it's a wonderful program because these people will not be drawn to the cities. They will probably stay there because they're settled. And then they'll have that career pathing because once they finish, get into a higher post, stay in that same hospital, but now they are regarded, they are better trained and better paid. They're not likely to move away, I imagine.
Do a lot more. They can do a lot more because now they've picked up a bit more expertise in terms of procedures and clinical management as well. Yes.
Yeah, that sounds great. So, do you all, as trainees, meet as a group at any point, even the ones in your program? How do you all come together as trainees, and how do you all come together is it all the training in Yahoo or in your specific hospital? How does the togetherness come along?
Okay, so for us at Yahoo Medical Center, there are about 11 of us currently in the various levels. So 11 family medicine residents, and we work in the facility. So our program is such that even though you are doing rotations outside the facility, you do what we call a fallback. A fallback is 1 day in the week or 2 times in the week when you actually come back to your primary facility. So for us, that would be Nyaho Medical Center. So we actually do meet as we do our fallbacks. So you may, some of your colleagues may be falling back on the ward, others will be falling back in the ER, others will be falling back in the OPD and all of that. So we meet on the ground as we are doing the work, and that equally helps us with our learning process because someone has seen something else in another place, someone has seen, you're able to discuss that. And then we have our clinical meetings as well. Thanks to COVID, we've moved all our clinical meetings to virtual.
True.
But we used to meet in the training room at the facility to actually get together as well and meet each other. And then we have joint meetings that we have with the Kolebu Teaching Hospital. So the family medicine department in Kolebu Teaching Hospital equally we run morning meetings with them, usually on Wednesdays and Thursdays in the mornings. Again, that's an opportunity to meet other trainees, first year, second year, third years as well. So you meet them on a regular. So almost every week you are able to meet other colleagues, either at Kolebu or in the facility. But now, because of COVID, all these are virtual now. All of these, unless you are actually on the ground and you meet on a fallback day. Yes. And then the college equally has the intro course. So first years that are admitted, family medicine the faculty has an intro course, which is usually a 1 week in September, where all that year group will come to Accra or to Kumasi, meet the consultants. Then you get it's more of an introduction course. So they expose you to the principles of family medicine, to all the various lectures you need before you even start the program, so that as you are going, you have some background that you are looking to apply and use in the training. So we have that intro course in the first year where we all meet as a year group. Then I think in the final year too, you have a revision course where you all meet again, Kolebu, Kumasi, Nyaho, we all meet in the same place, usually for the revision course as well.
Well, that's quite interesting. So, there's a good community of practice of sorts.
Exactly.
And I think that's really what you need to nurture you. Like you said, you need to be inspired regularly. And it's hard to see sometimes the family physician, but when you meet, it's easier to start picking up, okay, that's what I think we are.
Exactly.
So you've been, I noticed that you've also been involved in telemedicine at Nyaho, for virtual care. You've been doing some work. So how has digital health, e-health been part of your thinking, and compared to others as well? And how has COVID changed it?
Okay, so prior to 2020, we didn't have a solution. We didn't have a digital solution. We didn't have any means of telemedicine service for any of our patients. Right. And so in 2020, as part of the project, the strategic plans was to develop a telemedicine platform for the facility so that we can reach beyond Accra, so that we can reach a lot more people at their convenience and all. But then the process was sort of sped up by COVID. So somewhere in March, you have COVID coming in. We picked up our first 2 cases. And then there's all this chaos about where to go for care. Health workers are running away from positive patients and all of that. So we had to quickly work with our IT partners to develop a solution that we could run with. So I think somewhere by June, so somewhere in April, towards the end of April, we started doing a PCR service for the COVID-19 testing. And then one doctor was assigned to the COVID-19 hotline phone. So it was a doctor that was handling it, because at the point there were so many queries coming in, people having all sorts of questions, and we decided that it was better for a clinical person, somebody with some more knowledge to handle it. So I think that was where we started some sort of telemedicine service. So the hotline actually started responding to calls and queries from patients. And that same doctor equally would call patients who have tested positive. So he calls the patient, tells them that, oh, you did your test at Nyaho, your test is positive. Then usually they will ask a few questions are you having any difficulty breathing, any chest pain and all of that? Then based on your symptoms, they'll classify you as asymptomatic or mild. If they think that you are moderate, then they would now arrange for the ambulance service to get you to a facility and all of that. Initially, the national policy was that you call the national ambulance and the ambulance comes to pick you. But at the point, I think we had less than 200 ambulances in Ghana. And so obviously it was just not working. And so our hotline was one of the telemedicine tools that really picked up for a lot of people in Accra specifically. And then in June, we started using our platform. So we developed a platform with IT partners called Serenity. We developed a platform which was actually a video platform. So a video platform, a patient pays for the service. They are able to book for a doctor at any time. And then the doctor responds and has a video consultation with the patient. It's all encrypted on the platform. And the doctor has access to your medical history, is able to type in the notes, is able to put in some lab requests, is able to put in the medications, which is subsequently delivered to you at your convenience in the house, because most of those people were COVID patients who were isolating at home. So that service was actually very, very beneficial for the people that managed to do it. The only difficulty was that because it was paying, it was cash. And so those on insurance were limited. A lot of people didn't want to pay for that service. So we didn't pick up the numbers as we were expecting. And so from, let's say, I think end of June to about August ending, where I was leading the project, I saw about 35, 37 patients on the platform. And out of that, only one person actually ended up with an admission on the ward. And then one person was a patient who was discharged from the ward but needed a follow-up care. And then the other 34 were actually mild or asymptomatic patients who really needed some relief in terms of anxiety, some medical concerns that they had. They are losing their smell, they are worried, will it come back? They are having some headaches, will it come back? Will it go down? What should they take? And so you were getting a lot of requests that were coming in with very odd symptoms and presentations. But then I really, really enjoyed it because it was a new thing for us. You could see the joy in the hearts of the patients because they had really tried other alternatives to get care. They were probably not getting care, or they've gone to a public hospital. Health workers have probably shunned them in a way because of all the fear that was surrounding COVID at the time. And so once they actually are able to see a doctor, discuss their concerns, they're able to check their vitals, the doctor sees it and all of that, they really appreciated that service. And then we had a few people who were actually using the service for drug refills. So they were using it for drug refills because of the fear of coming into a hospital and picking up COVID. So some people were using it for drug refills. A few people actually contacted us for basic stuff. So I had an old woman who had a rash on the chest and wanted a consult. I had another person, I think, with the diarrhea. So I had a few more people who were non-COVID who equally contacted the service as well. So that's actually a service that is still running. So that my current rotations has really taken me out of the platform. Yes.
So I mean, being a private center, I imagine you'll have the wherewithal, especially with the patient base, to be able to set up this. Is the service, the quality of service you provide in Nyaho the same as, let's say, is experienced by those at Kolebu Teaching Hospital? And do the registrars or trainees learn the same thing in that space compared to what you do? How does it differ?
So comparing the two, I'll probably even say that quality of care is probably a bit higher in our place,
right,
in Nyaho Medical Center, as compared to the public space, because we have a lot of monitoring systems in place. We have patient satisfaction scores, there's feedback scores for each doctor. And so there's a lot of push to improve the care that we are delivering. We actually have a whole quality department with a couple of public health professionals who are there who are monitoring, keeping an eye on our metrics. And so I think that in terms of quality, we are probably a step further as compared to the public or even most of the other private facilities. But then if you look at the breadth of cases that we see in terms of our facility, I would say there is some limitation there in terms of the breadth that we see, because again, the public hospitals are free, they are cheaper, and so anybody will walk in with anything. For us, insurance, yes, so insurance brings in a lot more clientele. There are some companies who are paying for their staff to come to our place, and so you still see a number because we are seeing 100,000 people in a year. That's a significant number. But I think that the breadth in terms of what you see, the variety is a bit limited in our place. We are looking at gradually expanding our services. So now we've established one satellite clinic in Accra Central. And there's plans on the drawing board to establish a lot more of these in other areas of the country as well, so that you are much closer to the patient and you're able to see them at their point of need when they need it. And then if there's a need for sending on for secondary care, then you can refer them out to our main facility in Accra, in the airport residential area, or to other facilities that may be beneficial for them. So that is equally part of the reason why we are doing the training program, so that we have a lot of family physicians who actually be able to go out into the smaller satellite clinics that are being created to actually have a community of practice with your own professionals that you are working with, have a catchment area that you can follow up into the community. Because currently a lot of our work is actually within the hospital and the hospital premises. We don't go that extra step of getting into the community to actually change things.
Yeah, no, I think that's an interesting thing we'll come to just now. So just a quick thing to the participants: if you have any questions, please post them up in the Q&A, and feel free to contribute to the chat. I think it's also there, so don't feel that we are going on. We need to see and hear if you are also having some contributions you'd like to make. So I think there are a regular bunch of people who are always here, and it's great to have you every week. So just quick questions. You brought up this issue of you don't go out in the community. Maybe before you get there, you've been a clinical educator and also preparing licensing, the exams for physician, or you've been preparing them for the licensing exams. So you work closely with physician assistants. So where would you put them? I mean, in terms of you using them, or how do you use them? Are they mostly in the hospital or in primary care clinics?
So in our country as a setup, they are usually at the very lower ends of the primary care setup. So they are in the CHIPS compound, they are in the health centers, they are in the district hospitals. A few times you see them in a regional hospital or in a teaching hospital when they are doing their internships, when they are doing their rotations as well to become licensed finally. So I actually trained a couple of physician assistants. Usually they've graduated from school. They have a couple of months to write their licensing exams by the Medical and Dental Council. And together with my senior colleague, Dr. Laemi, we're able to organize some tutorials for them, a crash course for them to go and write their exam. It's one of the things I really enjoy doing, because you can make a bigger impact, because now you are dealing with 20 or 30 physician assistants who go into the community, who go into the primary healthcare centers or the CHIPS compound, and the knowledge you impact on them equally affects outcomes, even at that level and in the bigger picture. So I really enjoy it. And then it gives me the opportunity to actually read and revise and prepare my stuff over and over and over again. So currently, that is one of the things I do. I actually have a batch that started just about 3 weeks. They are preparing for their exam in April. I am hoping that once I finish the program, become a member, I'll be able to take on a formal role with any of the universities that actually train physician assistants. So it's one of the things I enjoy so much.
Looks like it. That's wonderful. So how long do they train for? You say they come out of school and then they get training. How long is the training for before they qualify?
Usually they do a 4-year degree program in the universities. in the College of Health. So they do their 4-year program, and then they come out. Once they come out, there are several exams in the year. I think there are 2 of them. There's April and there's September. So we get a group of them together, and then we usually within
prepare them for that exam.
2 or 3 months, we prepare them for the exam. It's more of interactive sessions. So before COVID, we're actually doing in person in a clinic, in a lecture hall in the clinic, and then we do that. A lot more theory because they are preparing for a written exam. And currently we are doing virtual. I deliver their tutorials by Zoom as well on the weekends for the 2 months before they write their licensing exams. And then after the licensing exams, they do a 1-year internship. 1-year internship, usually in a district hospital, in a teaching hospital, or even in some of the smaller facilities. Once there's a senior colleague, there's a specialist that can take you through the basics, what you need to do at the lower levels, know when to refer. So that's the key focus that we are training them to provide a healthcare person who will be able to provide some basic care and then refer appropriately, know where the red flags are so that they refer you appropriately. So that's what we are trying to do for them.
So do you see them as, I mean, how do you see teamwork between physician assistants, doctors, and other cadres in primary health care? Because Afro-PHC is trying to bring them together, but is there competition, and are people wanting to work together, or are there tensions?
Okay, good. So currently I'm at St. Dominic's Hospital, which is a district hospital, and it has about 300 beds. We have a number of physician assistants who are on the ground. Some are full-time staff, some are those in training. And then we have a number of doctors, you have nurses, you have specialists on the ground. We actually work as a team because in the ONG team, you have 3 or 4 physician assistants, you have house officers, you have the medical officers, and you have special. So we actually work together as a team. We go to the OPD together, we go to theater together, we go to the ward rounds together, and we are all working together to provide the care so that by the time they are leaving, let's say, this facility to go and work on their own in a health center, they will be capable to handle. So there's really no competition yet in our setting in Ghana. I probably maybe because the numbers are now building up in terms of physician assistants. So maybe in the future we'll have that friction of people trying to define their turf but currently there's really no competition. Good. It's more of a team that works together. They know where their limits are. They're able to do the basics that you expect them, and then you keep training them to get better.
All right. Well, just some questions about, reforms, and you mentioned it early on, and I mean, about, no, we do health insurance, but not Ghana health insurance. So tell us, what is the system like? And that's the universal coverage, the answer of government to universal coverage. So you're a young doctor looking at the future. Tell us what that's about and how you feel about it, before we finish at 4:00 of the hour.
Okay, good. So I think that universal health coverage is the ideal situation, and we need to keep striving to achieve that so that we can provide basic healthcare services to everybody whenever, wherever they need that care. And so using by the health insurance, by having a basic health insurance provision for everybody, that usually would drive that agenda more quickly than anything else. Having the health insurance developed, well-financed, will be one of the key things that needs to go out properly. In Ghana, we've had the health insurance running for about 15 years, probably. It's actually universal. It's actually very cheap and affordable. I would say so. An adult pays just about $3 for a year of coverage, which is really reasonable.
True.
There are a bit more challenges again because you have extreme poverty and all of that. And so that's still a challenge, but $3 is really, for a year, I think is a fair price. And usually a lot of people are able to afford that. So in the district hospital where I work, you get a lot of people coming in with the national health insurance. I think they have less than 10 or 15% paying cash for services. So that in itself is improving the universal health coverage in this catchment area. And then I think the other thing that really needs to go for us to be able to achieve that is to improve and speed up the training of the health cadre. So you need to produce a lot more health professionals so that you will be able to send them to all those places, and the healthcare is not so far away from the person. So in St. Dominic's, we have specialists, we have doctors, we have physician assistants, but there are people who travel about an hour or two on a very terrible road to come here, which is obviously not ideal, because even their lorry fare coming in and out to the facility is about $2 or even $3. So the same amount they need for a year of coverage, they have to spend on transportation, which obviously defeats the purpose. And so the person stays in the village, and by the time they come, it is extremely bad. So I think 2 or 3 days ago, we had to do some debridement for a young man, a 42-year-old sickle cell disease patient, whose whole hand had bad cellulitis. We had to debride almost the whole skin, subcutaneous tissue had to be taken out. We're just left with the muscles intact and the bones intact. And so people will stay so long because of the cost of just the transportation from their living place to the facility. And so training enough healthcare professionals is one of the key things that we need to be able to achieve this agenda. And then I think the other thing is provision of these smaller CHIPS compounds and resourcing them well enough. So I actually do some outreaches with an NGO, and when you go to the very remote areas, you go to a CHIPS compound and they don't even have a sphygmanometer, you don't have a glucometer, and you are wondering what kind of service are you providing to this community that you are manning? Because even though we still have a lot of infections running around, hypertension and diabetes is picking up. Hypertension and diabetes is really picking up here in Ghana as well. When you go to Kolebu, for instance, it's in the top 3. When you come to our facility, it's equally the top 3 as well. And so if the CHIPS compound doesn't have a sphygmanometer, then obviously we are not going anywhere in terms of achieving the goals of winning the battle against non-communicable disease. And then you go there, they don't have a rapid diagnostic test, some have faulty thermometers and all of that. So I think that establishing this CHIPS compound is ideal, providing basic things. They don't need ultrasound and all the big things, but at least sphygmanometer, some glucose strips and all basic stuff so that they can do the immediate and refer appropriately. So I think that those are 3 key things that really need to be looked at in terms of going forward and striving to achieve the universal health coverage, especially for us in Ghana.
Yeah. So if you were to look at the future as a young family doctor, would you go and be part of that process like GPs are doing, or would you say no?
Good. So that's why everybody chooses where they want to, or they genuinely feel they'll be more beneficial. So personally, where the part I want to play is to be able to provide the primary care for the patients that I'm seeing at Yahoo Medical Center. So if I'm sent to, let's say, a satellite facility, let's say at the outskirts of Accra, for instance, I'm willing to go and provide a service there. And then I want to equally get involved in the training process, because I think that is a key area as well that you can make some long-term impact. I can see maybe 30 or 40 patients per day, but assuming I train 40 more people, then they can equally multiply that reach and will be able to provide more care. So personally, yes, in my facility, I will continue with the provision of primary health care. We'll go to whatever satellite facility that we will develop in the future. And then I will get involved in the training as well. In terms of getting involved in policy and all those politics and all those things, I'm not too sure. Maybe some writings here and there, maybe some education on the TV programs and stuff like that. Yes, those are things I really look forward to doing. Yes.
Well, thank you very much, Daniel. It's been a really interesting hour. You've been very articulate in sharing all the stuff that's happening, and I'm sure that we can carry on and have other interesting discussions, but it's really been great to talk to you. On behalf of all the participants, thank you very much for taking the time out and sharing this. We hope we can capture it in an article that you can publish as well. So well done to you. I think you're going to be a fine example of a family physician and inspire many other people. So thank you all very much on behalf of Wonka Africa. Take care. Bye-bye. Enjoy your weekend. Be safe.
Thank you very much. Thank you very much for the opportunity.
Take care. Bye-bye, Daniel.
Thank you. Bye-bye.